have the honor to introduce Dr. Dennis Alexander Eichenauer. Sorry for my pronunciation. Dr. Dennis has been in medical school till 2007, where he had his license to practice medicine. He spent his residency in University Hospital of Cologne. Then he became the senior physician in the first department of internal medicine, University Hospital of Cologne in Germany. And since 2005, he's the study physician of the German Hodgkin Study Group in Cologne, Germany. In 2014, he had his board certificate of internal medicine, then in palliative care and intensive care medicine. We are pleased to have you with us, Dr. Dennis, as he's going to discuss today treatment of early Hodgkin. Pleased to have you, sir.
Thank you very much for the introduction and the invitation first. And within the next, I think about 30 minutes, I will talk about the treatment of early stage Hodgkin lymphoma. And the talk will be divided into two parts. One larger part in the beginning will be about the treatment of classical Hodgkin lymphoma. And in the end, I will briefly talk about the differences in the treatment of nodular lymphocyte predominant Hodgkin lymphoma. Well, first of all, before we start treating the patients with Hodgkin lymphoma after the diagnosis was made by a biopsy and histological workup, the patients require the staging to allocate them to a certain risk group, and this is done using or performing contrast-enhanced computed tomography of neck, thorax, and abdomen, and if available, the patients should also have a positron emission tomography in the beginning for a more detailed definition of the NIVAHL stage. In addition, the patients will undergo laboratory diagnostics, including blood chemistry, blood counts, and screening for some viruses, including HIV and hepatitis B and C. They undergo organ function tests, including ECG, echocardiography, lung function tests, and the thyroid function. And given the mostly young age of patients diagnosed with Hodgkin lymphoma, they are mostly in their 30s or 40s, sexual hormones. And also, due to the mostly young age of the patients with Hodgkin lymphoma, patients should also be offered fertility protection and oocyte or spermatocyte cryoconservation. As I said, I would start with the treatment of classical Hodgkin lymphoma. Classical Hodgkin lymphoma has an incidence of approximately 2 to 4 per 100,000 per year. The male-female ratio is approximately 1 to 1, so they are well balanced. And as I already mentioned, the median age at diagnosis is 33 years within studies of the German Hodgkin Study Group. Patients with classical Hodgkin lymphoma are diagnosed with early favorable stages in 22% of cases, and with intermediate or early unfavorable stages in approximately 40% of patients. And these two groups will be the ones I will talk about in the following. The patients with advanced classical Hodgkin lymphoma, who account for approximately 40% of patients, will not be covered in this presentation. Once the diagnosis is made and all the diagnostic workup, I presented 2 slides in the 2 slides before. Patients are allocated to 3 risk groups within the German Hodgkin Study Group staging system. The staging system from the EOTC for instance, very similar. The patients who present with stage 1A, 1B, 2A, and 2B without any risk factors are considered to have early favorable stages, and the patients with stages 1A and B and 2A with one or more risk factors of the following involvement of 3 or more lymph node areas, elevated erythrocyte sedimentation rate, large mediastinal mass, and extranodal disease are considered to have early unfavorable stages. And in addition, patients with stage 2B presenting with one or both of the risk factors, involvement of 3 or more lymph node areas and elevated erythrocyte sedimentation rate are also considered to have early unfavorable stages, whereas the patients with stage 2B having large mediastinal mass or extranodal disease are considered to have advanced stage disease. First, I will start with the treatment of early unfavorable stages, here with the patients who have classical Hodgkin lymphoma. Most treatments are also true for nodular lymphocyte predominant Hodgkin lymphoma, but I will come back to the small differences in the end of my talk. So for many years, until the late 1980s or early 1990s, patients with early stage favorable Hodgkin lymphoma were treated with radiotherapy alone. And a relevant proportion of patients was also cured with this attempt, but in the early 1990s, some randomized studies comparing radiotherapy alone versus combined modality treatment were conducted, and one of these trials was the German Hodgkin Study Group HD7 study, and the study that recruited patients between 1993 and 1998 compared extended field radiotherapy alone versus combined modality treatment consisting of 2 cycles of ABVD followed by 30 gray extended field radiotherapy. And as you can see on this slide, which shows the long-term follow-up with the 15-year estimates, the progression-free survival was significantly superior for the patients who had combined modality treatment with a 15-year estimate of 72.8% versus 52.2% for the patients who had radiotherapy alone. So that the results of this study and of some similar studies that were conducted by the ERGC and in the US led to the definition of brief chemotherapy followed by radiotherapy as standard treatment for early stage Hodgkin lymphoma. However, the question was whether we can still improve these results by intensifying the chemotherapy or giving more chemotherapy than only 2 cycles of ABVD on the one hand. And the other question was whether we can probably reduce the radiotherapy fields and doses from extended field to involved field and from 30 gray to 20 gray. And these were the questions in the follow-up study from our group, the HD10 study, that had 4 study arms and 2 study arms with 2 cycles of ABVD and 2 study arms with 4 cycles of ABVD, each followed by involved field radiotherapy and either 30 gray or 20 gray. And this figure shows the comparison of the least intensive and the most intensive study arm, comparing 4 cycles of ABVD plus 30 gray involved field versus 2 cycles of ABVD plus 20 gray involved field radiotherapy. And as you can see, there is no difference in the 10-year progression-free survival, so that it could be concluded that 2 cycles of ABVD followed by 20 gray involved field was non-inferior to 4 cycles of ABVD plus 30 gray involved field, so that the less toxic approach was adopted as a standard treatment when the results of the HT10 trial became available. However, still there was the question how we can maintain these excellent progression-free survival rates that translated into overall survival rates of more than 90% at 10 years. And the most recent randomized trials from different groups evaluated whether it is possible to omit the consolidation radiotherapy based on an interim PET. And the first trial that investigated PET-adapted treatment for patients with early-stage Hodgkin lymphoma was the RAPID trial that was conducted in the United Kingdom. And this is the trial synopsis. Patients all received 3 cycles of ABVD and then underwent positron emission tomography. And in the experimental arm, patients with a negative PET after 3 cycles of ABVD were randomized between no further treatment and the standard treatment consisting in 30 gray involved field as consolidation treatment. Patients with a positive PET after 3 cycles of ABVD received 1 additional 4th cycle of ABVD and underwent consolidation radiotherapy in all cases. Unfortunately, the aim of the study was not reached, but as you can see here, since the patients who did not receive radiotherapy after a negative PET at the end of chemotherapy did have a significantly increased rate of relapses, still on a high level with a 3-year progression-free survival of 97% for the patients who had a combined modality treatment versus 90.7% for the patients who had chemotherapy alone. But it was it had to be concluded that there was an increased rate of relapses for the patients who did not have radiotherapy, and radiotherapy therefore appears to prevent the patients from relapse even in the case of PET negativity. A very similar but significantly larger trial was the EORTC H10 trial that included both patients with early favorable stages and patients with early unfavorable stages. The patient included almost 2,000 patients, and the patients with early favorable stages all received 2 cycles of ABVD and then underwent interim positron emission tomography. The patients with a positive PET received a 3rd cycle of ABVD and followed by consolidation radiotherapy, whereas the patients with a negative PET were randomized between 2 additional cycles of ABVD without chemotherapy, and the patients with in the experimental arm with a positive PET received treatment intensification with 2 cycles of escalated BRCOP followed by radiotherapy. In the patients with early unfavorable stages, the patients also had 2 cycles of ABVD before a positron emission tomography was performed. In the standard arm, the patients all had 2 additional cycles after the PET followed by radiotherapy, whereas the experimental arms evaluated whether a chemotherapy alone approach with 4 additional cycles of ABVD was possible for the patients with the negative interim PET, and similar to the patients with early favorable stages, the patients with early unfavorable stages who had a positive PET at the end of chemotherapy also had treatment intensification with 2 cycles of escalated BRCOP followed by involved node radiotherapy at 30 gray. And As you can see here, at least for the patients with early favorable stages, the results were very similar to those seen in the already mentioned RAPID trial, with significantly increased PFS rates for those patients with a negative PET, with a negative interim PET who had chemotherapy alone, in comparison to those who had chemotherapy followed by consolidation radiotherapy with 5-year PFS estimates of 99% versus 87.1%. For the patients with early unfavorable stages, there wasn't the difference wasn't significant, but there was also a slightly non-significant difference between those who had combined modality treatment and those who had had chemotherapy alone, with rates of 93% versus 89.6%. For the patients with a negative, with a positive interim PET, the treatment escalation with escalated BRCOP instead of ABD appears to result in a significantly better progression-free survival, as you can see on the curves on the figure A, but there did not, at least not yet, translate into an improved overall survival. However, in patients, if an interim PET is performed, to have a positive interim PET and for instance, a larger lymphoma burden treatment intensification with BCOP escalated can at least be discussed. And this was the trial from our study group that addressed that also addressed the question whether treatment can be guided by interim PET. Patients with early favorable Hodgkin lymphoma all had 2 cycles of ABVD, and in the standard arm, they all received 20 gray involved field radiotherapy, irrespective of the PET results. And in the experimental arm, the patients with a negative PET did not have any additional treatment, but continued with follow-up. The patients with a positive PET, of course, had consolidation radiotherapy at the end of chemotherapy. And not unexpectedly, the results were almost identical to the RAPID trial and the EORTC H10 trial. The patients with a negative PET who had combined modality treatment had a significantly better progression-free survival of 93.4% versus 86.1%. And so that it can be concluded that the patients, based on the results of all 3 presented trials, that the omission of radiotherapy, even in the patients with a metabolic remission after chemotherapy, results in an increased relapse rate. This is particularly true for the patients who have a double score of 4 in the interim PET. Whereas the patients with a double score of 3 who were considered positive due to different reasons within the trials had a similar progression-free survival than the patients who had a double score of 1 or 2. So that in the clinical practice, we have a cutoff at a double score of 4 for PET positivity. So patients with a double score of 1, 2, and 3 are considered PET negative, and the patients with a double score of 4 are considered PET positive, and this correlates very nicely with the prognosis with regard to progression-free survival. So, as you could see on this slide, I rarely showed overall survival slides, but the reason for this was that all these trials were not powered to detect any survival differences. They were powered to show progression-free survival difference that often translate into an overall difference. overall survival difference with longer follow-up, but none of these trials could show an overall survival difference. So one could ask, why don't we spare the consolidation radiotherapy in patients with a negative interim PET and potentially protect them from radiotherapy-related late effects? If we do not see an survival difference if we irradiate them at the end of chemotherapy. And however, there are some analysis addressing this issue using databases, and this is an older analysis from Olszewski and colleagues that was already published in 2015 in the Journal of Clinical Oncology. And in this analysis that included a larger number of patients, some thousands of patients, also an overall survival could be shown for the patients who had combined modality treatment consisting of a brief chemotherapy followed by consolidation radiotherapy. So that our recommendation is to apply chemotherapy followed by radiotherapy in patients with early stage favorable Hodgkin lymphoma. Let's now come to the second part, the patient with early unfavorable stages. These patients are those with stage 1 or 2 and the risk factors involvement of 3 or more lymph node areas, elevated erythrocyte sedimentation rate, and the patients, except for those with 2-stage B, with large mediastinal mass and extranodal disease. And for a long time, these patients were managed with 4 cycles of ABVD followed by radiotherapy. And there are certainly some pros with regard to this approach. It is established, it is optimized for an outpatient setting. The acute toxicity is certainly manageable, and it's also feasible in resource-restricted settings. However, the PFS with 4 cycles of ABVD plus radiotherapy was significantly worse than the PFS in the patients with early favorable Hodgkin lymphoma observed after 2 cycles of ABVD followed by radiotherapy, so that in this patient population, the progression-free survival could certainly be improved. And the approach from the German Hodgkin Study Group HD14 trial was to intensify the chemotherapy, and the standard treatment consisting of 4 cycles of ABVD followed by 30 gray field was challenged by an experimental arm consisting of a chemotherapy with 2 cycles of escalated BRCOP followed by 2 cycles of ABVD followed by radiotherapy. And this approach resulted in a significantly better PFS with 7-year estimates of 93.7% to the 2+2 approach with containing escalated BRCOP versus 86.5% for the patients treated with 4 cycles of ABVD. But also in this group, the next trial generation tried to get rid of radiotherapy by a PET-guided approach, and this was the recently published German Hodgkin Study Group HD70 trial. After the standard chemotherapy within this trial was the 2+2 approach. So the standard and the PET-guided arm both had 2 cycles of escalated BRCA plus 2 cycles of ABVD as chemotherapy. And after this induction chemotherapy, the patients underwent positron emission tomography. And in the standard arm, patients had consolidation radiotherapy irrespective of the PET result, whereas in the experimental arm, the patients with a negative PET were only followed without any additional treatment, whereas the patients with a positive PET, i.e. a double score of 3 or 4, had consolidation radiotherapy. And as you can see here, in contrast to the trials in patients with early favorable stage Hodgkin lymphoma, there was no worse progression-free survival for the patients who were PET negative and did not receive radiotherapy, with very similar progression-free survival rates larger than 95%, and an excellent overall survival rate close to 100% at 5 years. So that in the setting of early unfavorable stage Hodgkin lymphoma, omission of radiotherapy based on an interim PET appears to be feasible, and patients, significant proportion of patients can be spared. So the overall survival is very similar between both arms. And what comes next for this patient group? Of course, there are novel substances, as you know, brentuximab vedotin, but also more recently checkpoint inhibition with nivolumab or pembrolizumab. In this context, our group conducted the NIVAHL study for patients with early unfavorable classical Hodgkin lymphoma. Patients received a combination of nivolumab and AVD, either concomitantly or with a run-in with nivolumab, and then the combination of nivolumab and AVD from cycle 2 on. And all patients had consolidation radiotherapy, because this trial was already conducted before the studies from the the results from the HD70 trial became available. And these are the results with a, of course, very short follow-up of only 1 year, but patients responded very well to this treatment. It was well tolerated, and there was virtually no case of recurrence after 1 year, so that this approach will be tested in a future phase 3 study against the standard of PET-adapted 2+2. Let me now come to the subtype of nodular lymphocyte predominant Hodgkin. It's very rare. It accounts for approximately 5% of all Hodgkin lymphoma cases. And so the incidence is 1 to 2 per 1 million per year. It is, in contrast to classical Hodgkin lymphoma, characterized by striking male predominance, and the median age at diagnosis somewhat higher. And importantly, the patients are mostly diagnosed with early stage disease. And this also includes a relevant proportion of patients with stage 1A disease without risk factors. And this is the only group of patients that is treated differently from classical Hodgkin lymphoma. And as you can see here, we compared different approaches in patients with stage 1A nodular lymphocyte predominant Hodgkin lymphoma, consisting of extended field radiotherapy alone, involved field radiotherapy alone, combined modality treatment, the standard treatment in early stage classical Hodgkin lymphoma, and rituximab alone, since the malignant cells in nodular lymphocyte predominant Hodgkin lymphoma consistently express rituximab. And so there's no progression-free survival difference with regards to the approaches extended field radiotherapy, involved field radiotherapy, and combined modality treatment, so that the widely accepted standard of care.
Again, we're having a problem with the mic.
Again,
sorry for that. Your voice is breaking up, Dr. Dennis.
Okay. I can hear I tested it again. I can hear myself very, very, very well. So
yeah, okay. You may go on.
I'm sorry, but yeah, I tested different times. I don't know if it's
Just for the clarity, it's a no problem. You may go again.
Okay, I'm very sorry. So it is very so this is very similar. So that the standard approach is in this setting is involved field radiotherapy alone, and this translates into into excellent overall survival rates, very close to 100% at 8 years. In a pediatric setting, in this rare entity, it also appears to be possible to do resection alone if one single lymph node is affected. And since these patients with a metabolic remission after lymph node surgery have a 5-year event-free survival of 75%, so that in a highly selected patient population, it can also be considered to perform resection alone if the histology is nodular lymphocyte predominant Hodgkin lymphoma. So that I already conclude, patients with stage 1A nodular lymphocyte predominant Hodgkin lymphoma without clinical risk factors are sufficiently treated with limited field radiotherapy alone. Nodular lymphocyte predominant Hodgkin lymphoma in all other early favorable stages and in intermediate or early unfavorable stages are treated with the same approaches as patients with classical Hodgkin lymphoma. Patients with classical Hodgkin lymphoma in early favorable stages should be treated with combined modality treatment, i.e. 2 cycles of ABVD followed by limited field radiotherapy. Radiotherapy can be omitted at the cost of an increased relapse rate, even in patients with a negative interim PET. And patients with early unfavorable stages should receive interim PET adapted treatment with 2+2, optionally followed by limited field radiotherapy. Thank you very much. I will try to switch it once again, okay? But okay.
Yeah, thank you so much, Dr. Eichenauer, for your comprehensive presentation on Hodgkin lymphoma. For our colleagues, if you have any question, please don't hesitate to ask your question or write your question in chat. Can I ask one question for you, Dr. Eichenauer? In some countries, there is no available radiotherapy machines, like countries in Africa or some regions in Egypt.
Mm-hmm.
Can we avoid radiotherapy in early stages, early favorable Hodgkin lymphoma in selected patients?
We do not have, unfortunately, we do not have any better tool than the PET available at the moment to identify patients who have a good response to chemotherapy. So that actually we cannot identify these patients. But I think in early stage disease, it is if there's no radiotherapy machines available, it is certainly justified to and these patients still have a good overall prognosis with these PFS rates of more than 80% at 5 years without radiotherapy, so that they still have a good prognosis. But the optimal treatment would certainly be a combined modality approach. So if there's a radiotherapy machine available, I would certainly recommend to irradiate them after chemotherapy.
Okay, thank you. Mohammed, may you?
Yeah, thank you, Professor Dennis. So for Egypt, let me say again, dealing with Hodgkin's disease, we need to be very, very, very cautious about the interpretation of the data. Usually because of the accessibility to the transplant, because the difference between the progression-free survival and the overall survival that you have mentioned in all of the trials, from the HD17 to the to the rapid, to everything. Omission of radiotherapy is not acceptable in resource-limited countries because of the accessibility to the transplant. Because if they don't have radiation therapy, definitely they won't have access to bone marrow transplantation. So it's very cautious here. We might overtreat a couple of patients, but it's definitely better than having a relapse or losing a patient to Hodgkin's disease. So basically, dealing with Hodgkin here in Egypt is we have to be very cautious about the interpretation of the data. Of course, me myself, I'm a pro for the BIACOB. Usually, although the gonadotoxicity and the myelotoxicity and the incidence of myelodysplasia, although I have been trained in the United States, so they're not a big fan there of the BIACOB. But for me myself, I'm a pro BIACOB because of the situation here in Egypt and the accessibility to the transplant. This is to talk about in the first hand. So BIACOB is a thing in early unfavorable and of course in all of the unfavorable cases. It has been very clear for the radiation therapy that in early stages it is very crucial. Whatever you overtreat the patient, if you give two cycles, 3 cycles, you always have a progression-free difference between cases who had radiotherapy or hadn't. So this is another thing that we have to bear in mind and to communicate clearly for our junior colleagues. Hodgkin in the early phases, it needs radiation therapy, especially in resource-limited countries. So this is just the interpretation that we need to convey and educate our junior doctors here in Egypt. There is no option to give 3 months of ABVD for early Hodgkin here, because if you have early Hodgkin and it had the relapse, they will be needing bone marrow transplantation, definitely. So we don't need that at hand. It's very costly, has a lot of side effects. It has a higher incidence of gonadotoxicity and myelotoxicity. So to sum up, just I'm just trying to interpreting what you have said earlier. But of course, thank you for the beautiful presentation that you went through. And thanks for Dr. Khaled for arranging all of this, of course.
Thank you, Dr. Mohammed. One question for Dr. Eichenauer from our colleagues here in chat. Can we omit radiotherapy in early unfavorable Hodgkin lymphoma after complete remission, after chemotherapy?
Based on the results of the HT17 trial, we can certainly omit radiotherapy in the patients with a negative PET. So if they're in complete metabolic remission after they had 2+2. We do not know about the situation if the patients are treated with 4 cycles of ABVD. This is a question that is not answered at the moment. But after an intensive induction chemotherapy with 2+2, you can certainly omit radiotherapy, but there are no data on how to proceed or on the role of interim PET after 4 cycles of ABVD and patients who have a metabolic remission at this after this chemotherapy. So likely they likely have a good prognosis, the patients who have a negative PET after 4 cycles of ABVD, but there is no hard data supporting or not supporting this.
Yes, thanks a lot, Dr. Eichenauer. Thanks, Dr. Khaled, for the arrangement. And we hope our audience had learned something new today. Thank you all.
Thank you. Bye-bye.
Thank you so much. Bye-bye.
Bye.